Hello everyone, welcome back to this series 3 for aneuploidy screening, and today we are going to actually discuss about the double marker ratios. As I always start my all the slides, that every pregnant female should undergo antenatal screening or aneuploidy screening. And learning points from our last videos are: a detailed history is always to be taken whenever you are offering aneuploidy screening. Exact age has to be calculated. Mode of conception should be very much clear. Scan findings should be known. And before jumping on to the ratios, always look at the mom levels of beta HCG, PAP-A as well as the scan findings. So, in case of Down syndrome risk in dual marker, it comes as basically low risk when it is less than 1 in 1000, or high risk when it is more than 1 in 250. So, there is one more category which is known as the intermediate risk. If it falls between 250 2000, then we call this as a intermediate risk. So some of the labs do report intermediate risk and some of the labs do just report high risk or low risk. So in case, so always just look at the numbers also, what type of risk it is. Don't just look at high risk or low risk, just look at the numbers, because according to the software, if they are not following the intermediate risk category, risk 1 is to 251 or 1 is to 252, they will call it as a low risk, right? So it is always very important to look at these numbers. So when a patient comes to you with this type of report, we have already discussed that we are going to look at the pregnancy details, all the hormones and MOM values, and then finally we look at the ratios. In this case, the final ratio is given to be 1 in 13,000, which simply means that the patient is at a lower risk for trisomy 21. And sometimes the patient asks whether the report is normal and abnormal. There is nothing normal, abnormal. This is a screening test which is simply giving the chance of having Down syndrome in their baby. So these numbers are like 1 in 13,000 means that if this report is reported in 13,000 patients, in these 12,999 patients will have normal babies, only one will have Down syndrome. So that one could be anyone. If individually we look at this report, this means very less chances of having a Down syndrome baby, and this test has a prediction value of around 90%. So this is how you have to explain to the patient regarding the low risk. And very important statement, that low risk does not guarantee a normal baby. This is to be explained to the patient in detail whenever they come to you with the report of dual markers. So when a patient comes to you with such a report, you will look at the ratios, and its combined risk is 1 in 69. So in this case, you can see age risk is 1 in 1000, biochemical risk is still high, but combined risk is 1 is to 69. That means somewhere there is some problem in the hormones. So now you will we will explain the patient that it is just a high risk. That means there are chances that baby is affected with the trisomy 21, but this is not a confirmatory test. So high risk does not mean that there is going to be an affected baby. So no decision is to be taken on the basis of any screening test, be it dual marker, quadruple or NIPS. So we will discuss with the patient about the further options to confirm the diagnosis, either by NIPS or invasive testing, and we will discuss about these options, their details, advantages, disadvantages in other videos. So you will discuss these options to confirm the diagnosis, because dual is still a screening test. And sometimes I told you the patient can, the report can come in this way also, where the risk for Down syndrome is around 1 in 640. Okay, so this is a kind of intermediate risk when it falls between 250 to 1000. So in these cases, you will just caution, give a word of caution to the patient that, see, you lie in intermediate risk. So we have various options. You can just go ahead, do the level 2 scan, look for any soft markers, and simultaneously you can also discuss the options of NIPS and invasive testing along with their pros and cons. So apart from this dual screening, some people do ask me, what is this integrated screening? So integrated screening is not routinely done in our setup, because this involves doing the first trimester screening, not giving any results, then the patient is again called in the second trimester, again the blood sample is taken from the mother, and it is the final integration is done between the first trimester markers, scan findings, second trimester markers, and then the final result is given in the second trimester. Okay. So, though it has a good advantage that it gives a 95% detection rate, but the disadvantage is that sometime the patient may not come in the second trimester for blood samplings, and in that case there will be no result given to the patient and generally has a poor compliance. So, integrated screening is not routinely done in our setup. Then there is one option which is stepwise sequential. So, stepwise sequential means you do the first trimester screening if it is a high risk or low risk. If it is a low risk, you do not give any result to the patient. You ask the patient to come at the second trimester and then give the final result. But if the patient is high risk, then you give the result in the first trimester itself, so that other options can be discussed, and these patients they do not have to wait till second trimester for any interventions. And nowadays what I am seeing most of the times is that patients patients are undergoing first trimester screen, okay, it is low risk, and then again at the time of level 2 quadruple test is also given, and we have seen many patients who are for FTS low risk and then they are high risk on quadruple test, which further increases the anxiety, the confusions, now what to do, and finally they will end up in doing one of the invasive test or NIPS. So, this is strictly prohibited, doing one screening test and other screening test without combination or without integration. So, ACOG 2020 clearly says that the use of multiple serum screening approach which is performed independently is not recommended, because that will lead to unacceptably high positive screen rates, and we have seen in our practice almost 100% of these patients were negative or they were normal. So, I would also suggest, if you have done FTS from a good center, from a good lab, anti-NB scan has been done good, then there is no role of doing quadruple in level 2 scan. If you want to offer a better screening test, better go for NIPS. So, apart from Down syndrome, say there could be high risk for trisomy 13 and 18 also on double marker screening. The risk is generally defined as high risk if it is more than 1 in 100. So, you have to actually counsel the patient, because these are trisomy 13 and 18 are very severe phenotypes, and they will always present with some of the scan findings if it is done from an experienced person. So, they will always show their features on scan findings, like in trisomy 18 there could be choroid plexus cyst, clenched hands, bilateral CTV, some cardiac anomalies. In trisomy 13 there could be associated holoprosencephaly. So, they will definitely show some of the features on scan findings, and again you can counsel the patient for the confirmation. Depending on level 2 findings, they can either opt for NIPS or invasive testing after discussing all the pros and cons. So, thank you everyone for patient listening. I have enumerated very important clinical basic points related to first semester combined screening. If you have any doubt, you can message me or mail me, and stay tuned. Thank you. Happy weekend. Enjoy.